Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everyone, and welcome back to the podcast. My name is Chuck Dowell. I'll be the host for today's episode. Thank you and welcome back. I hope you enjoy another case presentation. So this is a common thing that I think we all see in our orthopedic clinics and or our urgent care or primary care clinics. I live in the Colorado area, so we're in the middle of winter. So a lot of times we will see patients come in with kind of slip and falls on the ice or a lot of snowboarding and skiing injuries. This gentleman was a 22-year-old gentleman who presented to the orthopedic urgent care complaining of left wrist pain. Now, again, this episode will be a case presentation. There will be, visual presentation as well. You can see all the x-rays and images and other depictions that I discuss on the YouTube channel. So if you want to transfer over to the YouTube channel now, you can follow us along on that channel and be able to look at the x-rays and follow along during the discussion about the images I describe or depict during the podcast itself. So this gentleman was snowboarding, good conditions, caught an edge. He fell, put his arm out to try to catch himself, immediately felt pain within his left wrist, was done snowboarding for that session, tried to treat it conservatively with ice and anti-inflammatories, but woke up the next day or didn't sleep well that night with significant pain in his wrist. And then Monday morning presented to the urgent care clinic or orthopedic urgent care clinic for evaluation of his left wrist. Again, the x-rays are seen on the screen now. His physical exam, visual deformity was noted within the left distal radius. There was dorsal displacement of the distal fracture segment. Diffuse edema was noted throughout the area as well. A couple things when I'm evaluating these. Number one, obviously we want to look for any visual deformity. This deformity can help us to tell where the displacement may be. Again, if we remember from our radiological terminology, anytime we're describing displacement or angulation, we're describing the distal segment and how the distal segment is in alignment with the proximal segment. So if you're looking at the x-rays now, you can see that he has dorsal kind of angulation and 50% dorsal displacement of the distal segment. So again, this is that dinner fork deformity that we commonly see. So you can see on the screen now an image or illustration showing that dinner fork deformity. So that distal radius segment has that dinner fork appearance to it. We often call these the Colles-type fractures. So again, when I'm looking at the x-rays, I'm looking for the significant amount of displacement. The age of the patient definitely comes into play. This was a 22-year-old gentleman, so he is skeletally mature. We will discuss on part 2 of this podcast our pediatric patients with these distal radius fractures and their ability to continue to grow through this distal radius area. But part 1, I just want to discuss this patient itself. Again, if we're looking at the AP views, you can see there's loss of our radial height here and our radial inclination. There does appear to be some intra-articular component within this very ulnar side of that distal radius and kind of into that DRUJ section itself. And again, our oblique view shows very similar, complete loss of radial height and radial inclination with this dorsal displacement. So when we're looking at these as well, and we know that they have these full dinner fork deformities, we always want to check neurovascularly distally. One of the big concerns is all our neurovascular bundles run on this palmar or volar side of the wrist. And anytime we have this dorsal displacement, we will put some traction onto that area, and it could cause a neuropraxia secondary to that reason. So again, if you remember anatomy-wise, there's an illustration of the anatomy depicted on the screen now. Our median nerve runs through that carpal tunnel. Our ulnar nerve runs onto that ulnar side of the hand as well. And then we obviously have our radial and ulnar vascular structures and arteries within that side as well. This gentleman did have a little bit of neuropraxia, a little bit of numbness and tingling distally. So we don't want to leave these in this displaced position because if that traction on the nerve remains, it can cause some possible long-term nerve damage to the area. So the goal here is to try to close reduce this fracture and get it into an appropriate position. And if we can hold that closed reduction in a good position, he potentially won't require surgery. If we can't hold the closed reduction in a good position, he may require surgery. So he's a 22-year-old gentleman. He's skeletal mature. This is his non-dominant arm. We discussed with him about performing closed reduction in the orthopedic urgent care clinic. He was agreeable to this plan. Now, I don't have the ability for IV sedation, so when I see these patients in with these distal radius fractures and this displacement, I'll perform a hematoma block. And oftentimes I can get quite good anesthetics with these hematoma blocks. Majority of the patients that I do the hematoma blocks on will have a 1, maybe 2 out of 10 pain after the block is performed with performing this closed manipulation. So again, when we go back to the hematoma block itself, we want to try to, so if we remember that when we have a fracture that occurs, a hematoma will form around that fracture area. This hematoma provides this encapsulated kind of water balloon that if we can put an anesthetic in the area, it can give them quite good pain relief, not only for just pain control from the fracture itself, but also for us to be able to perform this closed reduction with minimal discomfort. And so I usually use about 10 cc's of lidocaine for this. Some patients or some providers will use lidocaine and bupivacaine to provide both short-term and long-term pain relief. Our goal here is to go through the dorsal aspect of the wrist, because again, our volar aspect has all of our neurovascular bundles and all of our flexor tendons on it. Our dorsal aspect typically is fairly safe. Again, when we're talking about technique, you can see as the illustration shows at this time, the hematoma will form around that area. So I'll palpate, I'll try to find the area where that step-off deformity is at on the dorsal aspect of the wrist. I'll go 1 centimeter or so proximal to that. That's where I'll enter the skin at. After fully, cleaning the skin with betadine or alcohol, whatever your preferred cleaning method is, you'll try to go at about a 30-degree angle with the needle here and go directly into that fracture. So you'll go all the way down to bone until you hit bone, and you're trying to go into that step-off deformity itself. You'll pull back on the plunger, trying to see if you can pull off some of the hematoma itself. Oftentimes you can, sometimes you can't. Even if I can't, I oftentimes still get a great block, even though I can't pull back and kind of aspirate some of the blood itself. If I can aspirate the blood, I'm always encouraged that I'm in the hematoma itself. And so sometimes if I don't pull back and get a blood filling into the chamber, I will maybe adjust my needle a little bit to see if I can find that area. If I can't, then I'll just try to put the anesthetist in the area. So I'll put about 3 to 5 cc's directly into the middle. And then you can see as the illustration depicts here, I'll try to fan out towards the radial and ulnar side itself, both times aspirating again, trying to make sure I'm in that hematoma. Again, a couple things about these hematoma blocks. Number one, ideally you want to perform these pretty acutely. So within the first 3 to 5 days of the fracture. If you try to perform this after 3 to 5 days, oftentimes some of that hematoma has reabsorbed and we won't get as good of an anesthetic with this. So typically if it's 3 days, I will perform the hematoma block. If it's 5 days, I'll warn the patient it may be an incomplete block. And if that's the case, they may have to go to the emergency room to have IV sedation if we feel like the fracture still needs reduction at that point. Number two, you want to give this plenty of time to allow the hematoma block to set in. I give every patient at least 10 minutes. I think oftentimes as providers, we get a little impatient. We try to go and manipulate the fracture itself prior to the full hematoma, the block setting in, and they don't get complete pain relief or anesthetics with it. So full 10 minutes to allow it to set in, and oftentimes patient will do well with this. You can see here as the illustration shows, this is a provider performing a hematoma block, a little bit more of a steep angle with their needle than I would normally perform. Again, I would normally go at about that 30 to 45 degree angle, trying to go proximal to where the step-off deformity is at and putting my needle right into that deformity itself. So that's what I did on this gentleman. I performed a hematoma block on him. I gave it 10 minutes. He did quite well. He said his pain was more of a 3 to 4 out of 10 with the manipulation itself, but he had significant and or improved pain relief. So again, when we're doing these closed reductions, technique-wise, you can see on the illustration here and or
the description here, in younger patients, that periosteum is quite thick, and that periosteum is intact. And so if we just pull straight longitudinal traction in those patients, we won't unhook that distal fragment, and we'll potentially won't get a good reduction itself. So when we're doing this, we're going to want to recreate the deformity. So I take both hands, I put them onto the wrist, I recreate the deformity, so I make the deformity worse. I then pull traction to try to get this dorsal segment up and over that hinge that it's sitting on, and you can see in the depiction here, recreate the deformity first, pull traction and try to get that dorsal hinge to sit into place, and then pull the fracture back over into place to hold it. Now, if there's a lot of dorsal comminution, obviously this won't work. So in this patient, there wasn't a significant amount of dorsal comminution. I felt like this method would work quite well. So again, you could see in the depiction here, we recreate the deformity with our thumb right here, kind of pushing on that distal fracture segment. I'll then either have my assistant push down onto the biceps area to give me counter traction to allow me to pull against it. There's a lot of different methods. One of our surgeons puts his foot, our leg around and kind of pushes down with that. You can use finger traps if you have them. I don't specifically have them. But then I'll try to get that dorsal hinge in place, and then I'll try to push it up volarly to try to manipulate that fracture into position. And luckily in this patient, again, with this, kind of minimally comminuted with a slightly minimal dorsal comminution fracture segment, I was able to get a good reduction. So you can see here my post-reduction x-rays show that the fracture segment is in a good position. There is still some dorsal comminution here, but I was able to improve that dorsal displacement to almost a normal position. And again, you could see here when we're looking at our AP view, I was able to kind of maintain our radial height and our radial inclination. So again, briefly, and we'll discuss more of this when we discuss distal radius fractures themselves, but 3 things we're looking for when we're looking at distal radius fractures is our radial inclination here. So we want that to be about 22 degrees, and that's this kind of slope of that radius from the ulnar, or the radial styloid to that DRUJ joint. We want our radial height to our radial length to be seen here as well. So it's not depicted here, but normally we want that radial length to be about 10 to 13 millimeters. So again, you can measure from that radial DRUJ joint to that tip of that radial styloid and look for the radial length. And then we're looking at our volar tilt. So we're looking at any tilt that could be present. And we want that distal or dorsal aspect to be higher than that volar aspect. And usually that's approximately 7 to 15 degrees or 11 degrees on average. And you can see here on the screen now an x-ray image with these different measurements in place. So again, radial inclination, kind of looking at that tilt to the radius, our radial length, and then our volar tilt. Hopefully that dorsal volar aspect is a little bit higher. So in this patient, I think we were able to get a lot of those back. Again, typically when they have a nice piece distally that doesn't have a significant amount of comminution, especially intra-articular component, these closed reductions will do quite well. So this is my post-reduction. So the second thing about these is you want to make sure that you mold the cast or whatever you're putting on there to not allow this to fall back off. Number 1 is getting a good reduction. Number 2 is holding that reduction into place. So usually we're not going to cast these because they will swell afterwards. We're going to put them in some type of splint. We want to put a splint above the elbow to control rotation. And so these ulnar gutter splints, these sugar tongue splints are what typically work the best. So this is what a sugar tongue splint looks like. Typically we can provide kind of orthoglass to go around the elbow. This will provide support with both rotational and any dorsal or kind of volar displacement. We want to go at least to the metatarsal heads and to get kind of a full distal splinting as well. But again, in this patient, I think the molding of the splint is probably the most important part. We want to have a volar mold. So you can see here, there's a little bit of a banana-shaped deformity to this, where I'm taking and I'm pushing, on my dorsal aspect here to try to make sure I'm molding that splint. So if it's going to fall off because of the forces of pull, it's typically going to fall off dorsally here again. And so I want this volar mold to make sure that it doesn't fall off into that dorsal position, because if it's going to go anywhere, that's the direction it's going to want to go. So I'll have this kind of 3-point mold to, form this splint. And so